Hi guys, this is chapter 47. This is nursing care of the child with alterations in immunity or immunological disorders. Some of the chapter is going to focus on HIV and allergic reactions, and we're going to try to hit both of those. So we are just going to get started here. So when we think about types of immunity, the first one we can think about is passive. This is when antibodies are received from an external source. So mom to baby through the placenta or through the birthing process, or maybe we give them IVIG, something external that we put into them. Cellular immunity is when antibodies are produced by native T cell lymphocytes. And humoral immunity are when antibodies produced by native B cell lymphocytes. So I'm not going to be super specific, but I want you to be familiar with the different types of immunities that we have. So what are some variations in our pediatric anatomy? We can talk about newborns receive passive immunity from maternal antibodies because of the placenta and or breastfeeding. The newborn exhibits decreased inflammatory and phagocytic response to invading organisms, increased susceptibility to infection, functional spleen at birth, and generally they have functional cellular immunity. Humoral immunity develops over time, so as we're exposed to different things, it builds our immunity system. And then the last variation is that young children have larger lymph nodes, tonsils, and thymus compared to the adult population. So that just gives you a little bit of variation between kiddos and adults as far as A and P. So let's talk about assessment of children with immunodeficiency, autoimmune, or allergies. So we're going to get a really good health history. Does the mom have HIV infection? Is there frequent recurrent infections such as otitis media, sinusitis, pneumonia? Do they have a chronic cough, recurrent fever, 2 or more serious infections in early childhood, extensive eczema, growth failure, right? We're going to think about all of those things that might have to do with immunodeficiency, autoimmune, or allergies. Then we're going to talk about family history. Family history could be positive for immune deficiency or autoimmune disorders, and that would help us guide our assessment. And then we're going to do that physical examination of our. So physical examination, we're going to inspect and observe, right? Least invasive to most invasive. We're going to plot our weight and our length or height on appropriate growth chart to see the trends. We're going to inspect the tonsil size, note any eczematous or other skin lesions that can occur with any allergic disease processes. We're going to document the presence of thrush. If they have frequent thrush, that could just be an immunodeficiency. And we're going to observe their gait. If they have unsteady gait, neurological alterations can occur with HIV infections. And then we're going to auscultate, percuss, and palpate. We're going to auscultate the lungs, listening for any adventitious sounds. Wheezing could indicate an allergic reaction. We're going to percuss the abdomen and determine the liver span. And then we're going to palpate for any lymph nodes. Some of the common labs and diagnostics that you may see are a CBC with differential, infection, inflammatory process, immunosuppressions are all going to probably put those counts out of whack. Immunoglobulin electrophoresis is going to help us determine any immune deficiencies or autoimmune disorders. IgG subclasses help us determine immune deficiency. Virologic assay, HIV, RNA, DNA. This is really a good diagnostic for HIV infections in children older than 2 weeks of age. ESR, and we'll see elevated in immune disorders, Rheumatoid factor, we will look at if we're thinking about juvenile idiopathic arthritis or systemic lupus. Anti-nuclear antibody, or ANA, if we're looking for lupus. RAST, or radio allergosorbent test, is kind of helps test with asthma and or food allergies. And then our allergic skin testing helps with also again testing for allergic rhinitis, asthma, checking to see what kind of allergies our kids may be allergic to that's causing some of those disorders. Common medications that we may see, immunosuppressants, cytotoxic medications, because those interfere with normal function of DNA. Corticosteroids are our anti-inflammatories. We may use those for juvenile idiopathic arthritis or lupus. IVIG provides exogenous IgG antibodies, usually indicated for primary immune deficiencies or HIV infections. Anti-malarial drugs help prevent flare-ups of lupus and JIA, or juvenile idiopathic arthritis. Disease-modifying anti-rheumatic drugs helps deplete DNA precursors and can be used with JIA. Antiviral medications bind to HIV-1 reverse transcriptase, helping block DNA polymerase activity and disrupting the virus life cycle. Immunizations, of course, we know those help prevent viral and bacterial infections, remembering that we cannot administer live vaccines to those that are immunocompromised. And then bone marrow or stem cell transplant. Bone marrow transplant, transfer of healthy bone marrow into bones of a person with immune malfunction. Stem cell transplant comes from donor or an umbilical cord or placenta. So after we've done a really great thorough assessment, the second step in our process is analysis. And some of the priorities for our patients may include infection risk, alteration in nutrition, altered tissue integrity, activity intolerance, delayed growth, and or pain. All right, so let's start looking at some of these. Primary immunodeficiencies, this is the most hereditary or congenital, and it's usually related to humoral deficiencies, cellular immunity deficiencies, or a combination of those. Phagocytic system defects or complement deficiencies. 10 warning signs of primary immunodeficiencies are listed here. If the kiddo has had 4 or more new episodes of acute otitis in a year, that could be a warning sign. 2 or more episodes of severe sinusitis, treatment with antibiotics for 2 months or longer with no effects, 2 or more episodes of pneumonia in a year, failure to thrive, recurrent deep skin or organ abscesses, persistent thrush or skin candidiasis, history of an infection requiring IV antibiotics, 2 or more serious infections such as sepsis, or family history of a primary immunodeficiency. All warning signs that we just need to be mindful of as we're getting our health history. So some of the primary immunodeficiencies include hypogammaglobulinemia, Wiskott-Aldrich syndrome, and severe combined immune deficiency. And I'm not going to go into great detail with these. Just be aware that these are primary immunodeficiencies. Secondary immunodeficiencies could occur as a result of chronic illnesses, malignancy, the use of immunosuppressive medications, malnutrition, prematurity, and HIV infections. And this chapter is going to really focus on those HIV infections. So 3.2 million children younger than 18 are living with HIV. Children acquire HIV vertically, meaning in utero or during birth, or horizontally, and that means transmission via unsafe needles, sexual contact with someone that has HIV. So they can acquire that either vertically or horizontally. Infants primarily become infected through through their mothers vertically, adolescents horizontally because of sexual activity or IV drug use. The virus replicates itself via the CD4 cell, which causes cell dysfunction, and then the B cell defects also occur and contribute to high rates of serious bacterial infections. Opportunistic infections occur due to T cell and B cell defects. Progressive HIV encephalopathy in children advance those neurological symptoms that will occur before immunosuppression happens. Some common signs and symptoms that are reported include failure to thrive, recurrent bacterial infections, opportunistic infections, chronic or recurrent diarrhea, recurrent or persistent fevers, developmental delays, or prolonged candidiasis. Medication therapy for children include antiretroviral drugs. This medication regimen can range from a single dose therapy if they're asymptomatic exposure to a highly active therapy when symptomatic. The more progressive the HIV, the more issues they have within their brain. So encephalopathy and neurological issues can occur, and we may see these again before that immune issues start occurring. So after we've taken a really good thorough history, we're going to do our physical examination, and that should be completed next. We're going to inspect and observe our patients first. We're going to note any fever. We're going to measure our infant. We're going to measure their weight, their height or length, and their head circumference and get that plotted on the growth chart so that we have a baseline measurement. We also need to determine their level of consciousness. They could be alert, oriented, or depressed if HIV encephalopathy is present. Then we'll look at some labs and diagnostics. PCR is the gold standard of testing. If it's positive, if it's infected infants are older than 1 month of age. So that is the gold standard. We'll do a PCR. It will be positive if the infant is older than 1 month of age. The ELISA test, or the enzyme-linked immunosorbent assay, is less accurate than the PCR. It may be positive in infants of HIV-infected mothers due to transplacentally received antibodies. So it may show up positive because of the antibodies from mom. These antibodies may persist and remain detectable up to 24 months of age. So you could have a positive ELISA test up to 24 months just based off of mom's antibodies that she has passed on, not necessarily that the infant or the child has HIV. The PCR, if it becomes positive after 1 month of age, then that is that own child infected cells. Other diagnostic or lab testing could be a platelet count or CD4 counts. So nursing management is directed at preventing or reducing infection. Infants that are born to moms infected with HIV will get a 6-week course of zidovudine. This is a prophylactic antibiotic to those HIV exposed patients. We're also going to, we have to promote compliance with that medication to prevent any progression of HIV disease and encephalopathy. Discourage moms from breastfeeding because we know HIV can be passed through breast milk. And that could be a really big ethical issue. So you're going to bring a big slew of people to come in and talk about that before you have that conversation. We're going to promote nutrition, increased calorie formula for our infants. Remember, they can be failure to thrive. So high calorie, high protein formulas for our infants and snacks for our kiddos. We're going to provide pain management and comfort measures. There's going to be lots and lots of education that goes out to the patients and the families. Adolescents about safe sex practices, using condoms with each encounter. Live vaccines can't be administered if they are immunosuppressed. And then we're going to make sure we're providing ongoing psychosocial support. So there are lots of stressors, right, with HIV. I think we've come a long way since it was first diagnosed, but we do know that this is a lifelong problem. Being diagnosed of an incurable disease will put a lot of stress on that family. They're going to go through lots of financial difficulties. The medication regimen can be very, very expensive. We can talk about multifamily members with HIV, right? Again, more stress, HIV-associated stigmas. Hopefully the stigmas have gotten better, but I still find that we get nervous, right? You walking into a patient's room with HIV, you just get a little bit more nervous. But being aware of your maybe stigmas of it. Sometimes a big stressor is when to tell that child about the diagnosis, right? At what age? I don't have a good answer for that for you, but when does the parent tell the child they have HIV for any reason? As far as family education for the child with HIV, medication regimen, ongoing follow-up, when to call if there's an infectious process going on, trying to reduce the stress. Sometimes support groups can be very helpful with that. And then again, we've talked about lots and lots of education. If a family calls, we just need to make sure we're reassuring them. This may be a family, especially with a new diagnosis, that calls multiple times with lots and lots of questions. So just make sure you're reassuring and you are empowering them with some education. Influencing factors for autoimmune diseases. So we are going to move into autoimmune disorders. These usually result from the immune system's malfunction. The body is manufacturing T cells and antibodies against its own cells and organs. So factors that might influence autoimmune disease include hereditary factors, hormones, self-marker molecules, and environmental influences such as viruses or certain drug categories. So autoimmune disorders include systemic lupus erythematosus, juvenile idiopathic arthritis, Guillain-Barré syndrome, myasthenia gravis, and dermatomyositis. We are going to focus on systemic lupus and juvenile idiopathic arthritis for this chapter. Systemic lupus is a multi-system autoimmune disorder. It can really affect any organ system, meaning the onset and course can be variable. It's rarely diagnosed before the age of 9. And when we think about assessment, we're going to do their health history. We're going to discuss the present illness and their chief complaint. We're going to do a physical examination, checking for temperature for fever, observing skin for a malar rash, documenting any alopecia, inspecting oral cavity for painless ulcerations, and joints for edema. So here are the most common clinical manifestations. Alopecia, or that hair loss. Anemia, we've talked quite a bit about. Arthralgia, which is joint pain. Arthritis, which is inflammation of those joints. Fatigue, lupus nephritis, and this is actually probably the greatest risk of death for our lupus patients. Patients may experience peripheral edema because of impairment of the renal function. So this should be your priority if you note this lupus nephritis. Photosensitivity, pleurisy, Raynaud's phenomenon, which is a condition that causes the blood vessels in the extremities to narrow and it restricts that blood flow. If you know someone that has Raynaud's, you'll see like their fingers turn kind of a really red purple color. They turn super cold, right? It's the extremities, those blood vessels narrowing and not getting any blood flow. Seizures, stomatitis, which is inflammation of that oral mucosa. Thrombocytopenia, decreased platelets can cause bleeding into the tissues. And then skin rash, particularly characteristic of a malar skin rash. So it is this is a very classic symptom of lupus, malar or butterfly rash. You can see this butterfly-shaped rash over the cheeks. And then we'll think about labs and diagnostics there. They will probably have a decreased hemoglobin and hematocrit, decreased platelets, and low white blood cell count. As far as nursing management, there's going to be long-term effects that occur. So, and they're going to need lots and lots of support. Management's really going to focus on preventing and monitoring for complications. This will include application of sunscreen daily to prevent rashes resulting from photosensitivity, instructing child to protect themselves against cold weather by layering up. If they're playing out in the cold for a long period of time, inspect those fingers and toes for discoloration, right? That's that Raynaud's phenomenon. Frequently checking blood pressures, we'll be talking to parents about that. Teaching to check urine output and monitoring for hematuria or proteinuria. Remembering if we have renal impairment, that could be very, very serious. Education for patients and family. Diet needs need to be healthy, regular exercise, adequate sleep, and then administration of medications for any pain, NSAIDs, corticosteroids, anti-malaria agents with mild to moderate lupus, with a step up to immunomodulators with those with more severe or frequent flare-ups of lupus. Juvenile idiopathic arthritis is the next autoimmune disorder that we're going to talk about, and this one mainly targets the joints. Inflammatory changes cause pain, redness, warmth, stiffness, and swelling. Juvenile idiopathic arthritis is formerly known as juvenile rheumatoid arthritis, but the name was changed because of the fact that rheumatoid factor doesn't come into play with our pediatric populations. So some of the types of juvenile idiopathic arthritis are polyarticular, which is 4 or fewer joints are involved. This is the most common type. Polyarticular, excuse me, 5 or more joints are involved, usually small joints affecting the body symmetrically. And then systemic. So not only is the joint involved, but fever, rash may also be present for diagnosis. So nursing management of JIA is going to focus on managing pain, medication prescriptions for inflammation and disease prevention progression will be given, maintaining mobility. Prednisone can be given every other day, and that's going to help maintain that joint mobility. Physical and occupational therapy may also be warranted to help with range of motion and muscle strength. Swimming is a very useful exercise to maintain joint mobility without placing pressure on those joints. And then we really want to just make sure we're promoting a normal lifestyle for these patients. Chronic pain could very much impact a child's psychological and emotional status significantly. So encouraging plenty of sleep or rest so the child has the ability to cope with those normal school functions. Encourage support groups, special summer camps to help children see that they're not alone in this disease process. All right, we're going to move into allergy and anaphylaxis. So allergy is an immune-mediated response resulting in an adverse reaction. The extent of the allergic response is determined by the duration, the rate, and the amount of exposure of IgE mediated reaction, including asthma, allergic rhinitis, atopic dermatitis, urticaria, digestive allergy, and systemic anaphylaxis. So we're going to look a lot closer at food allergies, anaphylaxis, and latex allergies. So we look at food allergies. This affects approximately 8% of our kiddos. It is, when we think about food allergies, that's a true hypersensitivity or allergy that is defined as an immunologic reaction. It's not, I'm allergic to bananas because I don't like bananas, right? It has to be an immunologic reaction in order to call it either a hypersensitivity or an allergy. The most common food allergens in the first few years of life are milk, eggs, peanuts, tree nuts, fish, shellfish, wheat and soy, sesame seed, and kiwi fruit. Peanuts, tree nuts, fish, and shellfish can persist into our adult life. These can occur within minutes of exposure to a couple of hours after ingestion. And signs and symptoms usually include hives, flushing, facial swelling, mouth and throat itching, runny nose, or GI reactions such as vomiting, diarrhea, nausea, that kind of thing. If you're having an extreme reaction, swelling of the tongue, uvula, pharynx, or upper airway could be life-threatening. So how are we going to take care of these patients? Management's going to include verifying that food allergy, discern a true food allergy from an intolerance, milk allergy versus lactose intolerance, right? Some of us get a little bellyache if we drink milk. It doesn't necessarily mean it's an allergy. Maybe it's just an intolerance. So verify that food allergy. Avoid the allergen, so making sure we're removing that allergen from the diet and then treating the reaction. And this could be either with an antihistamine or epinephrine. And the nursing and assessment is going to include assessing the airway, breathing, and circulation, right? ABCs should be your priority when we're talking about nursing assessment with food allergens. Allergy skin prick test or that RAST test. Just remembering that testing may have false positive, which lead to children losing or avoiding foods unnecessarily. So food-specific IgE is recommended with any history of food allergies. Oral challenge could be slowly eating that food allergen over the course of an hour and then monitoring the presence or absence of any symptoms. And then trial elimination diet could include eliminating the diet or eliminating that food from the diet for 1 to 2 weeks and then retrying that food one at a time to see if they have a similar reaction that might occur. Anaphylaxis is an IgE-mediated response to an allergen that involves many organ systems and could be very life-threatening. If more than one immunological reaction is occurring in different systems, it's considered anaphylaxis. So nausea and vomiting with airway constriction would be GI and respiratory anaphylaxis. If you've got airway constriction with hives, anaphylaxis, that's respiratory and integumentary. So 2 different systems are involved with the IgE-mediated response. Therapeutic management for these may be assessment and supportive ABCs. Again, right, we want to make sure they can breathe, their airway is open before they can breathe, and talk about circulation. Epinephrine usually is required, so that's your EpiPen, EpiPen Junior, and if that is required, then that child has to take that wherever they go. We can also talk about intramuscular or IV Benadryl as another therapeutic management for anaphylaxis. So as we continue thinking about nursing management, supplemental oxygen by mask or bag valve might be required depending on that airway, right? If their airway is blocked, we may have to be bagging for them. Epinephrine to reverse the allergic response. If they've got some bronchospasms going on, we're going to use a bronchodilator for that. IV fluids for volume expansion, and then we're going to really observe them for a couple of hours to make sure they don't have a recurrent attack. So if that EpiPen is given, it's observation automatically for 2 hours to make sure that they don't have a rebound or recurrent attack. So we talked a little bit about EpiPens, I believe, in concepts. So just making sure you know how to utilize that EpiPen or EpiPen Junior. It can go through clothing. You got to get it into them as fast as possible. So reading the directions, this one here still says 10 seconds. A lot of them now are about a 3-second hold. So you're grasping the pen, you're taking the gray safety cap off, you're swinging and you're jabbing that into that outer thigh at 90 degrees because it's an intramuscular, and you'll hold it for whatever it says, 3 seconds, 10 seconds, whatever it may say. When we talk about latex allergy, this is an IgE-mediated response to the exposure to latex. it can result in anaphylaxis. So we need to be very mindful of that. Lots of our gloves, lots of our equipment used to have latex in them. I think as that exposure to latex and the anaphylaxis was recurring in our patients, we've really cut back as a health care system to make sure there's not a latex exposure for any of our patients. We need to determine if the child has an allergic symptoms after eating foods. That's the thing that's going to get them, are the foods that have that cross-reactive latex. So pears, peaches, kiwi, grapes, cherries, melons, bananas, avocados, cherries, tomatoes, potatoes, and plums. And I put, celery, not cherry twice, celery. So lots and lots of foods have latex. So again, that's a great education piece. We're going to assess for hives, wheezing, cough, shortness of breath, and or nasal congestion. And that concludes chapter 47. If you have any questions, you can shoot me an email or we will chat about it in class. Thanks, guys.